When we talk about surgical asepsis, there are a lot of key principles that we want to keep in mind whenever we are completing a dressing change. We want to be sure to keep all sterile objects above waist level. It is also very important to never leave our sterile field unattended or turn our back to our sterile field. If for whatever reason we need to leave our sterile field to maybe go gather more supplies, we always want to have a licensed professional watching our sterile field. It's also important to never reach across our sterile field, and we want to remember that once the sterile drape is placed, there is a 1-inch border around the edge of the sterile field that is considered unsterile. We want to remember the concept of capillary action, and this will play an important role when we talked about wet or packed dressings or any dressings in which we may have to place ointment on. There are 3 main reasons in which we complete a dressing change. The first would be to clean the wounds, and this would be done to remove any drainage that may have collected in the wound or if the wound has become contaminated. The second is to protect the wound, and this is done to promote tissue growth and repair. And the third reason would be to debride a wound. Debriding a wound simply means to remove any dead or infected tissue or material from the wound to help promote wound healing. When determining the type of dressing to use on a specific wound, it is very important for the nurse to assess the characteristics of the wound first. The nurse will oftentimes work very closely with the physician or the wound ostomy nurse when determining the appropriate dressing. Skin prep is oftentimes used prior to the application of a dressing to provide a barrier of protection over that vulnerable skin surrounding the wound and to protect it from any moisture or mechanical skin injury. Transparent films or tegaderms are oftentimes used to protect small pressure injuries for wounds. We may also see these used over peripheral IV sites. Transparent films are clear and semi-permeable and prevent external bacterial contamination. Foam dressings provide a water-absorbing surface that are great for wounds with moderate to heavy drainage. The moisture-absorbing surface provides a great layer of protection to the surrounding tissue and skin. You may also see foam dressings, also called Mepilex, used over bony prominences to protect things like the coccyx, elbows, heels from skin breakdown. Gauze dressings, often referred to as 2x2s or 4x4s, are used in a variety of ways for wound dressings. They may be used for cleaning a wound. They may be placed on top of a wound to provide protection. We may use gauze dressings to apply ointments to a wound. And they may also be used to pack a wound. When removing an old dressing, both clean or sterile gloves may be used. The nurse must use both critical thinking and judgment to determine whether clean or sterile gloves is appropriate for that situation. If it is anticipated that the glove will come into contact with the wound itself when removing the old dressing, then the nurse should use sterile gloves. Whether clean or sterile gloves are used during the removal of an old dressing, the nurse must hand sanitize or hand wash prior to applying a new pair of gloves. If there is not a sink available in the room, the nurse is encouraged to bring in hand sanitizer. This would avoid leaving the wound unsupervised while completing hand hygiene. Measurement of wounds are always done on the initial intake of a wound and then per hospital protocol, which is usually about 2 to 3 times a week. Measuring a wound helps to determine if the interventions being used for that specific wound are appropriate. The size of the wound is determined by measuring both the widest and longest point of the wound. The depth of a wound is determined by inserting a sterile applicator or cotton tip into the wound and then holding that next to a ruler to determine the depth. With each and every dressing change, the nurse must both assess and document the characteristics of the wound. This would include examining the type of tissue that is in the wound. The nurse would also assess for any drainage from the wound. If there was any drainage, the nurse would want to document the amount, the color, consistency, and if there was any odor present in the drainage. The nurse should also assess the peri-wound, which is the area surrounding the wound bed. It is also very important to document the client's tolerance to the procedure. As the nurse, you may need to develop a pain management plan to ensure that your client is comfortable during the dressing change. If the client is medicated prior to the dressing change, it is important for the nurse to ensure that the medication has reached its full effect prior to starting the wound change. Anytime a client has a wound, regardless of the size or extent of the wound, the nurse should be continuously assessing for signs and symptoms of a wound infection. Local signs of a wound infection would include any purulent drainage or odor in the wound bed. Other local signs may include any increase in redness, tenderness, or pain at the site. Systemic signs and symptoms of a wound infection would include things such as an elevated temperature or an increase in white blood cells. There are multiple key points that the nurse must remember and apply each time a central venous catheter dressing change is completed. Throughout the dressing change, everyone in the room must have on a surgical mask. The client must either wear a mask or turn their head to the opposite side of the venous catheter. While cleaning the site, a back and forth motion must be used for at least 30 seconds. The nurse should also allow for at least 30 seconds for the site to dry before applying the BioPatch and Tegaderm. Anytime the nurse comes into contact with a BioPatch, whether removing the BioPatch or applying the BioPatch, the nurse must remain sterile. During all central venous catheter dressing changes, it is crucial that the nurse maintains strict sterile technique to prevent any local or catheter-related bloodstream infections. Following a surgical procedure, the client may have a drain placed. Some of these drains are sutured into place, where others are simply placed into the wound cavity. Drains allow for both fluid and exudate to exit the wound bed. A Penrose drain is a flexible, flat latex tube that is oftentimes just placed into the wound cavity. These drains are rarely sutured into place. The drainage from the Penrose oftentimes collects into a gauze pad. The nurse should frequently assess for an increase in drainage and change the gauze pad as needed. A T-tube is most commonly placed in the bile duct to help drain excessive bile while the surgical incision heals. The T-tube is collected in a small drainage bag. Oftentimes, the nurse may have orders to flush the T-tube once a shift to help maintain patency of the tube. It is important that the nurse pay close attention to both the amount and the frequency of the T-tube flush. Other commonly used drains are Jackson-Pratt drains and Hemovac drains. Both of these drains are sutured to the skin, and the drain is connected to either self-suction or wall suction. In order to create that self-suction, the bulb on the Jackson-Pratt or the drain on the Hemovac must remain compressed at all times. It is extremely important that the nurse maintain strict I's and O's when completing the emptying of a Jackson-Pratt or Hemovac. The physician uses this information to determine if the drains are still needed. If a client has more than one Jackson-Pratt, they should be numbered. It is important that each output from each Jackson-Pratt is entered separately into the I's and O's. After the nurse empties the drain, it is important they use an alcohol prep pad to clean the port to prevent any contamination of the drain. Cleaning a wound helps to remove any drainage or microorganisms from the wound. It also helps to promote healthy tissue healing. Most commonly, normal saline is prescribed when cleaning a wound. However, you may also see Dakin solution, which is an antiseptic solution used for wound clearing. When cleaning a wound, it is extremely important to make sure that the nurse always cleans the wound from top to bottom or from center outward. Before collecting a wound culture, the nurse should always clean the wound bed prior to prevent any false results that may occur from any skin contamination surrounding the wound or sitting on the top of the wound bed. When completing the culture, the nurse should press the swab against the granulating area of the wound bed to express fluid from the wound tissue and rotate the swab using a rolling motion. The nurse should avoid areas of necrotic tissue or any areas in the wound bed that contain pus. Obtaining a culture from this material would not produce a reliable result, since pus oftentimes indicates that the microorganisms have already died. If ointment was prescribed for the wound, the nurse should apply ointment to the sterile field using a sterile technique. Using the same technique as cleaning a wound, applying ointment should be completed with a sterile cotton tip applicator or dry gauze from a top to bottom or center outward motion. Depending at the healthcare facility that you work at, you may also hear wet to dry dressings referred to as wet to damp dressings. These terms are used interchangeable. When packing a dressing, you want to apply a moist gauze to the wound bed. Be sure to place the gauze in all the depressions and crevices of the wound. You may need to use a cotton applicator to ensure that you fill all the depressions of the wound. It is also important to make sure that you fluff the gauze prior to placing in the wound, so as it dries, it acts as a wick for any drainage. You want to be sure that the moistened gauze does not come into contact with any healthy peri-wound area surrounding the wound. The packed dressing is then covered with either sterile gauze and or a abdominal pad or ABD pad to help protect the wound from external contaminants. If the wound bed is large, it is oftentimes packed with either 2x2s or 4x4 gauze pads. However, if the wound is small and narrow, it may be packed with thin gauze, also referred to as new gauze. It is extremely important to remember when packing this type of wound, only one piece of new gauze must be used to ensure that no gauze gets left inside of the client during a dressing change. Depending on the type of wound, wound irrigation may also be ordered with every dressing change. Irrigation of a wound should consist of a back and forth motion from top to bottom to prevent the flow of contaminated solution over the cleaned area. Using a syringe size of 30 to 60 mL provides enough pressure to effectively remove any bacteria or exudate from the wound bed. The nurse should ensure that the solution being used to irrigate, along with the inner cannula of the syringe and the syringe tip, all remain sterile during the irrigation process. Prior to irrigating a wound, the nurse should assess the client to see if any pain medication needs to be administered beforehand. A wound vac uses negative pressure wound therapy to promote wound healing. Wound beds help to prepare the wound for closure. They also assist in reducing edema, promoting granulation formation, and help to remove any infected material from the wound bed. After sterile black foam sponges are inserted into the wound bed, it is then covered with a sterile transparent dressing. A small hole is cut into the transparent dressing, allowing a vacuum tubing to be attached. This tubing is what created the negative pressure. A collection chamber is attached to the wound vac. These collection chambers also allow the nurse to assess the type of drainage that is being pulled from the wound bed. Wound vacs may also be portable, which can be used for clients that are ambulatory or patients that are home in the home setting. A client may have a wound vac at home, and they would then be followed by a home care nurse. The goal is for the suction to remain on for 24 hours a day.